Good afternoon. I'm Lee Kyung-hoon from the Division of Hematology and Medical Oncology at Seoul National University Hospital. In this session, I will give an overview of the subtypes of breast cancer and anti-cancer treatments. It is important to distinguish between subtypes of breast cancer, and many patients might already be aware of their specific subtype. Knowing the subtype of breast cancer is crucial as it determines the treatment, making it the most important prerequisite for chemotherapy. Many of you might have heard about undergoing chemotherapy after breast cancer surgery, or some may have been advised to start chemotherapy before the surgery. You might wonder, why do I need chemotherapy when my doctor said that if the surgery goes well, everything will be all right? You might also worry whether the surgery was inadequate or if cancer cells remain in the body. You are likely aware that chemotherapy can have many side effects. I'm also aware of that, and I also prescribe chemotherapy to my patients, but of course, it is not a pleasant thing. But despite being a tough treatment, chemo ultimately benefits the patient. You might be worried about hair loss, premature menopause, and the impact on fertility and work life. But lately, with the advancement of medications, there are options like hormone therapies and targeted therapies, so it's natural to wonder, why not opt for these instead of chemotherapy? Before we dive into that discussion, it might seem unrelated, but considering the differences between a cold and cancer could be helpful for today's discussion. Chemotherapy is used because it is developed with an understanding of cancer as a disease. Take a moment to think about the differences between a cold and cancer. Although there are various differences, a cold typically results from external pathogens, often viruses, while cancer, although sometimes its cause is known, generally arises from mutations that develop over time within the body as we age. So the idea is that cancer arises from internal causes within the body, whereas a cold comes from external sources. Another point is that a cold naturally improves over time. I remember hearing during my first internship after medical school that if you treat a cold with medicine, it takes 2 weeks, and if you don't treat it, it takes 15 days, which is essentially the same. With cancer, it's different. It's a progressive disease that, if left to its natural course, it leads to severe health deterioration and often results in death. So that's a big difference. There may be questions around medicine or drugs. Are there medicines for the common cold? What about cancer? In general, for a cold, we might take various medications for cough or runny nose, which might make it seem like a cure for cold exists. However, in reality, there is no direct cure for the common cold of the virus that causes cold. Exceptionally recently, medications that inhibit the coronavirus were developed. There were such medications for the flu, but it's important to note that for the common cold, there aren't any medications that directly target the cold virus itself. In contrast, cancer medications are indeed treatments for cancer. They directly treat the disease itself. Therefore, there's a distinction between how colds and cancer are treated when it comes to drugs. Chemotherapy, for example, treats cancer. However, developing drugs that target external pathogens is generally easier because it involves distinguishing between external agents entering the body and the body's normal physiological functions, making drug development more straightforward than for cancer. Because cancer cells share many fundamental survival processes within our normal cells, creating drugs that target cancer cells inevitably means that some normal cells will also be affected. This is why chemotherapy has side effects. Cancer cells, while functioning much like normal cells in their basic processes, are characterized predominantly by their ability to rapidly multiply from one cell into many. This disease produces a high number of cells from a single origin, and these cells do not just stay in one place. They invade, which is the case of invasive breast cancer, and metastasize as well. Breast cancer cells should remain within the breast, but they can also spread to other parts of the body, such as the liver. This behavior is abnormal, and if the proliferation is uncontrolled and excessive, it can threaten the survival of the individual. However, the basic survival mechanisms of cancer cells uh, are very similar to those of normal cells. Breast cancer is a type of cancer that occurs in the breast. Fundamentally, since we are mammals, the breast is an organ for producing milk, which is essential for nurturing babies. Therefore, the breast is critical during the childbearing years, but afterwards, it is not essential for individual survival. In women, the mammary glands develop during puberty as a secondary sexual characteristic and naturally regress after menopause. This regression also occurs after childbirth. Breast cancer arises in the tissues where milk is produced and released for breastfeeding. And there are several classifications of breast cancer. This is one of today's key topics. The role of hormone receptors in classifying breast cancer. Estrogen is the most well-known female hormone, and there is also progesterone, another female hormone. We discuss these in terms of positive and negative. Positive means the hormone receptors are present, negative means they are not present. And in cancer cells, this is expressed as hormone receptor positive or negative to describe this presence or absence. This can be confusing because when discussing tumors, benign means good or harmless, whereas malignant means bad or harmful, indicating a cancerous tumor. So, benign and malignant are terms used in English to differentiate between cancerous and non cancerous growths, while positive and negative in this context refer to the presence or absence of hormone receptors. Similarly, HER2 is an important target present in cell membranes and relates to targeted therapy. 20% of breast cancer cases, or 1 in 5 patients, overexpress HER2. Like hormone receptors, HER2 is also classified as positive or negative. Therefore, we can categorize breast cancer into 4 types based on the presence or absence of hormone receptors and HER2. Hormone receptor positive, HER2 negative. That's one. And then hormone receptor negative, HER2 positive, or hormone receptor positive and HER2 positive, and hormone receptor negative and HER2 negative. Typically, cases with hormone receptor positive and HER2 negative are defined as hormone receptor positive breast cancers. In such cases, hormone inhibitors are a key treatment, and the necessity for chemotherapy is assessed based on individual circumstances. Thus, for hormone receptor positive breast cancer, hormone inhibitors, specifically those that inhibit female hormones, are typically used by default, and the addition of chemotherapy is optionally considered. For HER2 positive cases, the treatment involves both chemotherapy and targeted therapy for HER2 by default. And if the hormone receptors are also positive, hormone therapy is added. To recap, the basic treatment for HER2 positive breast cancer is chemotherapy plus targeted therapy for HER2, with hormone therapy added if the hormone receptors are positive. In cases where estrogen receptors, progesterone receptors, and HER2 are absent, it is referred to as triple negative breast cancer. In this case, the primary treatment is chemotherapy, as targeted therapies are not applicable. The categorization of treatments based on cancer type is the most important topic for today. The use of chemotherapy has both benefits and costs. Chemotherapy can be beneficial for the patient, but it is also costly and can cause suffering. In the world of medical treatment, there are always trade offs between benefits and drawbacks. Nothing is entirely black or white. All medicine involves weighing benefits against the costs, especially adjuvant therapy following surgery occurs after visible cancer cells are removed by surgery. The cancer is cured by definition. However, if there is a significant risk of recurrence and if drug therapy can reduce this risk, additional drug treatments are administered. Thus, even if the primary tumor size is small, there may already be cancer cells that have spread beyond the breast. The concept behind using chemotherapy is to eliminate these invisible remnants that might remain in the body. Breast cancer chemotherapy is broadly categorized based on the timing of administration into three types. The first is adjuvant chemotherapy. The term adjuvant suggests a supplementary role following surgery. It is provided after surgery to reduce the risk of recurrence. The second type is neoadjuvant chemotherapy, which means it is a new kind of supplementary treatment. This is administered before surgery to reduce the size of the tumor, making the surgery easier. The third type is palliative chemotherapy, which is used when breast cancer has metastasized to such an extent that curative treatment is no longer feasible. In this case, alleviation is the focus, not surgery. In stage 4 cancer, the goal is not to cure, but rather to provide palliative care. While surgery is considered the most crucial treatment, it is supplemented by chemotherapy, hormone therapy, targeted therapy, and radiation therapy to reduce the risk of local recurrence. These are collectively termed adjuvant therapies, meaning they support the main surgical treatment. I believe that in the case of breast cancer, these adjuvant therapies are just as important as surgery itself. To use an analogy, it's like when there are weeds among crops. Surgery is like physically pulling out the weeds, and there might still be some seeds left, which could be targeted with a lightning strike akin to radiation therapy. But in cases where it's difficult to distinguish between normal cells and cancer cells because the weeds have overgrown, you would spray pesticide to try to kill just the weeds while sparing the crops as much as possible. Even in early stages, clinical trials have shown that hormone therapy and chemotherapy can reduce recurrence rates and ultimately increase overall survival rates. For instance, young patients with stage 1 breast cancer may have a significant risk of recurrence, but hormone therapy can reduce this risk by a certain amount and chemotherapy by another amount. Combining the two treatments can reduce the recurrence rate even further compared to just one treatment. In older patients with the same stage, hormone therapy may not be as effective as in younger cohorts, as hormone therapy will reduce the risk this much and chemo this much, but the combination of both therapies can significantly reduce the recurrence risk. So, undergoing chemotherapy after surgery is tough, but it's done to improve survival rates. While it would be challenging for the short term, in most cases, patients with axillary lymph node positive patients undergo chemotherapy. Even if there are no affected axillary lymph nodes, it is common for young patients with large tumors and those with hormone receptor negative cancers to undergo chemotherapy. However, nowadays, genetic testing like Oncotype DX, among others, is used to determine if chemotherapy is absolutely necessary for the individuals. As mentioned earlier, neoadjuvant chemotherapy is administered before surgery to reduce the size of the tumor, making the surgery easier. And palliative chemotherapy is used in cases where the cancer has already metastasized and curative treatment is difficult. The aim here is to alleviate symptoms, manage the disease, and improve the quality of life and life expectancy rather than to cure. Regarding the duration of chemotherapy administration, it is typically done in cycles repeated after 3 weeks. Adjuvant chemotherapy is administered over 3 to 6 months, and the same duration applies to neoadjuvant chemotherapy, which is administered before surgery. For metastatic breast cancer, chemotherapy is administered as long as it remains effective. Generally, patients receive chemotherapy once every 3 to 4 weeks, followed by a waiting period. The schedule is planned as such because chemotherapy affects not only cancer cells but also normal cells. The body needs 3 to 4 weeks for crucial crucial blood cells to recover and regrow. The side effects of chemotherapy are a significant concern as the treatment primarily targets fast growing and dividing cells. This includes hair cells, epithelial cells in the mouth, and cells in the gastrointestinal tract, which can lead to symptoms like mouth sores, diarrhea, and mucosal damage. Nausea or loss of appetite are considered acute side effects of chemotherapy, arising immediately after treatment. However, these usually improve quickly over time. While some acute side effects may persist, they generally resolve. It's possible during treatment for side effects to emerge and usually subside once treatment concludes, though recovery can vary among individuals. Very rarely, some chemotherapies can cause abnormalities in kidney function or blood cells or lead to early menopause or infertility by suppressing ovarian function. Young patients who want children should consider these risks beforehand and make appropriate arrangements before starting chemotherapy. In conclusion, the risk from chemotherapy can never be zero. All medical treatments carry inherent risks and benefits, and these vary from patient to patient. Deciding on the best course of treatment should involve discussions with your doctor and careful consideration of your specific circumstances. Listen to your doctor's recommendations to make an informed decision. Thank you very much for your attention.